A 59-year-old male presented with sudden onset diplopia with a previous history of cerebellar stroke. I am showing you T2 weighted DWI and ADC axial brain MRI sequences. Describe the findings.
Okay, assessing the provided imaging. The brain MRI scans demonstrate focal, symmetric T2 weighted hyperintense signal changes located within the bilateral paramedian thalami. On the diffusion-weighted imaging sequence, these paramedian thalamic lesions exhibit marked bright hyperintensity representing restricted diffusion. This restricted diffusion is corroborated by corresponding low signal intensity on the apparent diffusion coefficient map. No other acute abnormalities are identified on these limited brain MRI sequences. The imaging findings are diagnostic of acute bilateral paramedian thalamic infarctions.
What is the diagnosis? And what are the main differentials for bilateral thalamic hyperintensities and restricted diffusion?
In that case, the diagnosis is an artery of Percheron infarction, which is a rare cause of acute bilateral thalamic ischemic stroke. The differential diagnosis includes deep cerebral venous thrombosis, top of the basilar syndrome, and hypoxic ischemic encephalopathy. Deep venous thrombosis causes bilateral venous congestion and infarction, but it typically spares arterial territories and involves the internal cerebral veins. Top of the basilar syndrome causes midbrain and thalamic ischemia, but also involves the superior cerebellar and posterior cerebral artery territories.
Explain the anatomical variant of the Artery of Percheron and why its occlusion leads to this specific infarct pattern.
Well, the thalamus has 4 major vascular territories, typically supplied by multiple small perforating arteries arising from the posterior cerebral and communicating arteries. The Artery of Percheron is a rare anatomical variant where a single, solitary dominant perforating branch arises from the P1 segment of one posterior cerebral artery. This single trunk bifurcates to supply the paramedian thalami and the rostral midbrain on both sides. Consequently, occlusion of this dominant artery leads to symmetric, bilateral paramedian thalamic infarctions, with or without midbrain involvement. The clinical presentation is dominated by sudden onset altered mental status, vertical gaze palsy, and memory deficits.
What are the metabolic, toxic, and infectious causes of bilateral thalamic signal abnormalities, and how do you differentiate them?
Okay. Wernicke encephalopathy affects the medial thalami, but typically also involves the mammillary bodies, periaqueductal gray, and tectal plate. Wilson's disease affects the ventrolateral thalami rather than the paramedian zone and is associated with putaminal and pontine changes. Variant Creutzfeldt-Jakob disease exhibits the characteristic pulvinar and hockey stick signs, involving the dorsomedial and pulvinar nuclei. West Nile or Japanese encephalitis present with acute febrile illness and also involve the basal ganglia bilaterally.
Discuss the management, prognosis, and how you would manage this patient as a radiologist.
Acute management involves urgent thrombolytic therapy or endovascular thrombectomy if the patient presents within the therapeutic window. Long-term stroke team management is essential to prevent secondary emboli and support cognitive rehabilitation. CT angiography of the neck and head should be performed to evaluate the basilar artery tip and identify any source of embolism. As a radiologist, I would immediately call the stroke team to report the findings, allowing for timely thrombolysis or anticoagulation.